in our 30-day EKG challenge to have such a special guest with us. So Jan is going to introduce herself and give you all the details on her background, but she's a longtime PA, and she's offered to share with us a provider's viewpoint on billing and coding. Now, in case any of you are wondering, and it's funny because Jan said to me, oh, billing's like dry toast. But it's funny because while that some people may think that, it's actually one of the most important things that we do, because as PAs, we have to be, and providers of any level, we have to be profitable for our practice. We need to be team players. We need to generate income. And if you're RVU-based, this also directly affects your pocketbook. So many different reasons for this to be wonderful knowledge. And we're very grateful, Jan, to have you as a special guest. So please take it away.
Thank you. So as Jennifer was telling you, my name is John Kelly. I am coming to you from Knoxville, Tennessee. She very politically correct said long-term practicing. I will go ahead and tell you that I'm old. I have been practicing for over 20 years. And currently, I feel like this topic is coming to you at a relevant time for me because it has changed so much. So in reviewing the guidelines, and as you will learn, 2021, they made a lot of changes to billing and coding. And for me, I have to say, and for those of you that are also seasoned, I think it's particularly difficult for us to adapt because it is such a significant change from how we were initially taught. But interestingly, it is actually a lot easier and the burden is a lot less. And so the focus on the changes actually is to try to help providers capture reimbursement and RVUs for their time, and for the documentation to be more meaningful, opposed to it just being a 30-page novella that really doesn't help you understand what's going on with this patient or distinguish them one from the other. So I am faculty with Lincoln Memorial, and I'm finishing my doctorate, which I don't know if that's a reflection of self-loathing at this point in the program. I work in cardiology, and I've been in cardiology for over 20 years. And then in the last 2 years, have started doing some indigent care free based family practice. So it has really affected my need to learn more about billing and coding. Because what you need to know, I have found, for a specialty practice versus family practice is very different. So the big disclaimer is I'm not a billing and coding expert. I'm a provider that's been billing and coding my notes for a long time. I use a lot of different EHRs because I'm in different practice settings. And so this is my knowledge and interpretation of the current guidelines in collaboration with other providers, and particularly with some of the really lovely resources that I have available to me with billing and coding within the places that I work. So having said that, just a little bit of background. So HCPCS, I didn't even know what this means. So Healthcare Common Procedure Coding System. So what is this? So this is the system by which we bill. So there are 3 different levels. Level 1 is where you're putting in your CPT code. So those are your common procedural terminology codes. So this is for a procedure. So the purpose of a CPT code, as you probably know, is to capture a charge for a procedure that you have done. So the definition being medical, surgical, diagnostic, and other services. And this is something that is defined by the American Medical Association. So as you know, this is a combination of numbers and letters. There'll be 5 characters. It will begin with a number, and then you can add modifiers to it. So an example would be a 99204, which would be a new patient level 4 evaluation and management code. And at times, and if people have questions about modifiers, yes, you can add modifiers, but that's a whole complexity within itself. So then you also have level 2 codes, and these are things that are not included in a CPT. So these are things that are talking more about vaccinations or consulting with a clinical worker, clinical social worker, or nutritionist. So these are other codes, again, alphanumeric. This one, opposed to beginning with a number, however, begins with a letter. And this also does have modifiers available. So the thing that we're real familiar with, and if you are old like myself, the ICD-10 codes. So this is how we term a symptom, a diagnosis, a disease, for a patient. And so this also is regulated by Centers for Medicare, so CMS, and Medicaid. And so October the 1st, these are released every year. These have exploded. So they've really gotten into, and it'll make more sense as we go through this, trying to make your codes as specific as possible. And the reason to do that, aside from torturing us, is to help establish the complexity of the patient. So for instance, where you used to just put 401.1 for hypertension, now they're going to want, that code's going to be more extensive, and it's going to say hypertension stable, controlled, hypertension uncomplicated versus hypertension with retinopathy. So now the codes are very specific. And the reason for that is to identify the complexity of the patient, because that affects your billing and reimbursement now. So as of October of 2022, we're up to 72,748 codes. And I'm sure we all have them memorized. So the codes also, so for example, BMI, you used to just have a code for obesity or elevated BMI. And now for those of you that are familiar, if you put BMI in, then they would want you to expand BMI elevated 30 to 34.9 or 35.0 to 36, with or without comorbid conditions. So again, these codes keep expanding to make them more specific to your patient. So on your E&M codes, so these are your evaluation and management codes, these are the codes that you're using to actually bill. So the important thing to know about your E&M codes is to be clear if this is an established or a new patient. So an established patient is someone that has been seen within your practice within the last 3 years. For it to be a new patient, they cannot have seen you or provider within your practice for 3 years. And so those codes, the 992s, and then 1 through 5, and you can see a list of those. So the 1-1, that would be like a nurse visit. And so that's something that you usually are not even involved in. Actually, you can also bill for patient calls, for which most people don't do because patients get upset about it and don't want to pay a copay for a nurse calling.
Wait, tell us more about that. That's interesting.
I will. Let me get through, but I will.
Okay.
Yeah, you can bill for that. It just tends to tick your patients off.
Okay.
And then so you have the 1-2 for minor problems. Most of us are going to be billing 3s and 4s, and particularly if you're in specialties, you're primarily probably going to be billing 4, because most often if you're in a specialty, you are seeing or treating 2 or more chronic illnesses or somebody with a new problem. So for instance, a 4, in my mind, I would not have thought of a level 4 as someone coming in that I'm seeing for high blood pressure and high cholesterol. But if in my assessment and plan, if I put hypertension and then I identify that I have assessed and treated it. So if I put hypertension stable, continue medications per MAR or continue lisinopril. And then if for number 2, if I put hyperlipidemia, current LDL goal less than 70, has met goal on current statin therapy, continue medication with refill, that is actually a level 4 because I am managing and addressing 2 chronic illnesses. So most of us are probably under billing because I think that's been emphasized to us so much to not overbill. So then we have our E&M codes for new patients. And the big change is that the 99201 has gone away. So there's no such thing as in 2021 as a 99201. All of your new patients, which again means they've not been seen for 3 years, are going to be a 99202 through 99205. So when you're thinking about documentation, and this is something also that was kind of mind-blowing to me. So, back in the day, I feel like this is what we were familiar with. You had to have a certain number of elements documented. So you had to have a certain number of review systems. It was important that you included past history. And then if you were doing a level 4 or above, family history, social history, that you had so many elements of the physical exam. And these things have gone away, which we will talk about further. So the things that you were always documenting are your chief complaint, your history of present illness, and your chief complaint can be mentioned in the HPI. I would strongly encourage you not to do that. If it is not clear to someone that is coding your note what the chief complaint is, then they will kick it out. So I really encourage you to put chief complaint, and that needs to be the first thing that you read. And that can be a quote from the patient. So, again, I'm practicing in Knoxville, Tennessee. I have a new nurse. So one of my patients today, their chief complaint was itch and butt crack. So very scientific, but that was their chief complaint. Obviously, we expanded on that on the history of present illness. So your past medical history, family and social history, this only has to be documented now as it is pertinent to the visit, which we will talk about a little bit more. And on your review of systems, where we used to have to click so many elements, you had to complete so many components of a review of system and the physical exam. While these things still need to be documented, the current guidelines say you only have to document what is medically relevant to the conditions you are assessing and treating. So what does this mean? So if I'm seeing somebody that comes in with congestive heart failure, then I would want to document that their weight is stable, they denied dyspnea, their NYHA class is not changed, no edema, palpitations, etc. But I would not have to document things that I might have documented before out of habit, like saying no headaches, no visual disturbances. So I only have to document the things that are pertinent to that visit. So that I think is interesting, and that it is not necessarily consistent with what you need to document for medical legal liability, if that makes sense. So while I might not have to document from a billing standpoint whether or not somebody has a headache that I'm seeing for hypertension, but from a medical legal standpoint, I should be documenting if they are having new onset of headaches. So I do think it's important when you're thinking about billing and coding to remember that there's billing and coding for RVUs and collections, but that does not always coincide with what you need to be documenting for a medical legal standpoint. So things that you would always document: chief complaint, which can be included in the history of present illness. It needs to be very clearly delineated and identifiable. Your medical history, review systems, and physical exam. These three components are relevant, are needed and necessary to the extent that you feel is medically relevant. And then the final part that has to be included is your assessment and plan. And so there's an acronym MEET, meaning for your assessment and plan, you have to not just put the diagnosis, but you have to either put that it is being monitored, evaluated, assessed, or treated. So for instance, I could not put my first code or my first ICD-10 hypertension and then not put anything after it. I would need to identify it further. So I could put stable, controlled with current medications, continued DASH diet, continued blood pressure levels, but I have to document something after that code to prove that it is being monitored, evaluated, assessed, or treated. If you do not do that, then it does not count as one of the conditions. So other elements that used to be required, this is an example of them. So these are for review systems and physical exam. These are no longer required. You only have to do what is medically relevant to the exam, which is a huge change for me, and I'm sure to others if you've been doing this longer than 2021. So these are the big highlights. These are the big changes. So for 2021, the big changes, and this is only for outpatient. Inpatient has not changed. But for outpatient, you are coding now based on the complexity of the patient. So it is not coding based on the review of systems or the physical exam hitting so many checkpoints. You are billing and capturing collections based on the complexity of the patient. So you bill one of two ways. It's either the medical decision-making or by time. They encourage it to be by medical decision-making. But sometimes time is an easier way. And so the reason they did this is because when we went to EHRs, all of a sudden we started printing short nonfiction books on patients, right? Everything was copy and paste, and somebody came over and they had expansive records, but you still could shift through all that just to find the 4 or 5 sentences you need. And it didn't necessarily reflect what was going on with the patient. It was just tons and tons and tons of documentation that was generated by data input into the computer. So to try to get away from that, they have now gone to your billing and coding being based on the complexity of the patient. So now your documentation is meant to reflect how difficult your medical decision making is for this patient, and or the amount of time. Now, what's interesting about time is they are not talking about time in the room face to face with the patient, which is how I always think of time. They actually now give you credit for any amount of time that the provider, so the person that is billing that day, not for the clinical staff, but that the provider sends on that patient. And I will expand more on that shortly. So things that are essential to this type of coding: the chief complaint has to be clearly documented. You include the elements of the history, review of systems, physical exam that you think are medically relevant. So you do not have to populate a certain number, and this is a huge change. So you only document what you feel is medically relevant. Now, again, that is not necessarily consistent with what you feel you need to document from a medical legal standpoint. Your assessment and plan is to include any and all conditions that are being assessed or managed. So if you are taking into consideration, for instance, if you saw somebody with palpitations and they have an ICD and they have documented PVCs and they're on an antiarrhythmic and they're on anticoagulation, all of these things should be listed. It should not just be listed that the person had palpitations, because what you're trying to do by listing all those other diagnoses is establish that this is a highly complex patient, and that goes towards supporting a higher level of medical decision making. And so again, the time is to include all the time you spent on the patient on the same date of the encounter. So this is something that I think is important to think about depending on your practice. So if you have a patient that comes in and you are in the practice of ordering their labs that day, then unless your labs are result of the same date, your interpretation of those labs could not go to add to your time for that encounter or for the complexity of the patient. So example, if I saw someone and they were coming in 3 months post-MI and they had newly documented cardiac disease from that MI, that was their initial the first time they've been diagnosed with coronary disease, and they've been started on a statin. So I'm going to see them and I'm going to order lipids. It would be more beneficial for me to capture a higher level of complexity on that patient if I had them come in with their labs and we reviewed the labs that day. Because if I'm reviewing the labs that day on the date that I'm submitting that billing, then that goes towards part of my time or part of the medical decision making. Whereas same patient, if I ordered labs that day, but did not interpret them with the patient, and then they come in the following day, but not the same 24-hour window as the charge that I'm submitting, then I cannot bill for interpretation of those labs. So that is kind of a lost charge, or lost time, lost element to your billing now. So that is something to consider, that you want to try when possible to do things on the same encounter so that you can include that in that same billable period to increase complexity or time. And then the other changes, of course, the 99201, so the new patient easy is deleted. And there is, and this is something we can talk about if there are questions, an add-on code, the GPC1X, and this is for highly complex patients that are Medicare that exceed 75 minutes of time. And if that's where you are, God bless you, because that's a long time. So when we're talking about billing based on medical decision making, so again, this is the change. So you can see here in 2019 and 2020 versus 2021, we've now gone from the total actual time, where before it was just the face-to-face counseling. And again, before, the medical decision making was based on documentation of review of systems and physical exam, where now it is based on the morbidity and mortality complexity of the patient or the total time. So let's talk about billing by time. So if you were billing by time, so the first step when you see a patient is, are they new or are they established? so that you know which code you're using. And if this is a newer established patient, if you were thinking that you were going to bill by time, then things that would include in the time would be preparing to see the patient. So before you go in the room, you are reviewing their old records, you're reviewing old tests, you're reviewing old hospital data, old chest x-rays, labs, etc. That is part of your time. So the clock has started on time that you are accumulating towards treating that patient. And then again, obtaining and reviewing a history. So not just you obtaining the history, but for instance, information that your nurse or MA may have collected for you. So if you walk in the room and you say, hi, this is who I am, let's review some of this data in your chart, that goes towards the time. So then the time performing the exam, so all this kind of goes into the face-to-face time, counseling and education of the patient or caregiver, ordering of tests and procedures. So this is different. So the big things that are different here is the time you spend before you go in the room and the time you spend on the patient when you leave the room. So if I spend 10 minutes prep work before I see a patient, and then I go in the room and see the patient, and that's another 15 minutes, I'm at 25 minutes. And then if I sit down and I put in their prescriptions, I order their test, I put in referrals, and then I document and I spend another 10 minutes documenting, all of that goes towards my time. So that is a big difference and kind of a big reward, because in the past, you just had a 15-minute visit with the patient and that's it. And so now if you spend more than that time, it does goes towards billing by time. So an example, and this is something you'll want to talk to your department about. So per Medicare, there's a short and sweet version. So if you say, I spent blank minutes today, excluding procedures on patient care, that is sufficient for Medicare. That is not ideal, however, and this is why. Patients now see their records. So if a patient looks at their record and they are like, no, she didn't, Miss, that PA that I saw, Jennifer Colquitt, she was amazing and she had this beautiful blonde hair and she had we had a great interaction with her and I really appreciate the card, but she was in there and out of there in 10 minutes. She interrogated my ICD, she upped my meds and she's out there. She was not in there for 40 minutes. So the reason that this is not ideal is not because it's not correct. It's not because it's not acceptable to Medicare. It's because if patients see their records, they may not like this and they may contest it. So having said that, what I would suggest is having something a little more wordy, but once you get in the habit of saying it. So if you are more specific, so if you put, I spent blank minutes today reviewing records, obtaining history, performing physical exam, reviewing tests, documentation, ordering tests, sending medication, patient education, device interrogation. If you can just do a quick blurb, then if the patient goes back and looks at this, it justifies that time. Because remember, the patient doesn't realize what you do before you come in the room or when you leave the room.
Hey, John, there's a question actually. Great info. So inpatient was unchanged from prior, like number of points addressed?
Inpatient is the same. So
Yeah.
if when you're talking about seeing
Okay.
patients inpatient, you still need to be capturing a certain number of elements, review of systems and physical exam.
Thank you so much.
Yeah. So an example of billing by time, and again, let me tell you, this makes me so uncomfortable because this is just not at all consistent with how I would document. But if you're going by the new guidelines, if I saw someone, then this is acceptable, which is insane to me because it looks so small. And I normally would have this whole big thing on their review of systems and physical exam. But by current guidelines, this is acceptable. I would pose the argument, I don't think that this is excellent practice if this were a medical legal thing. So chief complaint, ongoing abdominal pain, clearly marked, clearly obvious what the chief complaint is. HPI patient here to discuss her ongoing abdominal pain. All tests have been negative, denies rectal bleeding. That is what that provider feels is medically relevant. Now, if it were me and I'm not in GI, there would be a lot more relevant things that I would want to document, for instance, and I'm sure everybody could contribute to this. It would be important to me to say if they had a change in weight, eating habits. I would want to describe the abdominal pain. I would want to know about change in stool, bowel patterns, etc. To me, it would be relevant. Their family history, if they have a history of colon cancer. It would be any IBS, ulcerative colitis, I would want to know past medical history if they've had other inflammatory diseases. But again, if I do not feel that it is medically relevant, I don't have to document any of that, which is mind blowing to me. So the exam, again, it's just what this person feels is medically relevant. So their exam, they just did mildly tender right upper quadrant. That's it. That's all they put. And so then their assessment is generalized abdominal pain. And so this is their documentation. So they are basing their documentation, they are billing by time here. So on plan, they are putting 30 minutes and they're going through all the things that they reviewed. So x-rays, CAT scan, GI series negative labs, lifestyle treatments, pharmacotherapies. They're going through. So this clearly has the monitored, evaluated, assessed in their plan. So you can see, so this person is going to submit billing for 45 minutes. So that is how they are going to bill. Okay. They are doing this based on time. I'm just curious, does this make anyone else feel like a little uncomfortable?
Yes, absolutely.
Yeah, I was going to say to me, I mean, and I took this example specifically and sat down with 2 coders and called somebody from AMA to make sure. And again, so by billing criteria, this is completely acceptable for a level 4 visit or a level 5 even. But this is not my opinion. This is not medically legally appropriate, but you are now billing by time based on the complexity of the patient. So again, not how I would do it, but this is what the update is. So another example. So this is someone that's coming in with hypertension. So they're coming in for an evaluation after starting blood pressure, stating that their blood pressure has been stable. This is their physical exam. And incidentally, they're noting that this patient has a wart. So now in their assessment, they're documenting hypertension and a wart. So you can see in plan that they are, again, that MEAT algorithm. So monitoring, assessing, evaluating the hypertension. So they're saying that it's stable, avoiding the foods, continue the medications, and that's where they go. And then they've added to their assessment, so then adding to their plan a viral wart. So this is billing by time for a total of 15 minutes. And that's how they're doing it. Now, this is a very important distinction. You cannot bill for the time that you spent doing cryotherapy because that is a separate. Okay. So if you do something else that is billable as a separate charge, so for instance, cryotherapy, trigger point injection, ICD interrogation, if you have something else that you are doing and that is a separate billable code, then you cannot bill for that time. So that is important. So you can see here in their documentation, they put 15 minutes exclusive of procedures because you cannot include procedure time because you bill separately for that. So that is billing by time. So billing by time, it's the total time you spent getting ready to go into that room to evaluate that patient, the time spent with the patient, and then the time that you spend dispositioning the patient and tidying up their care. So anything that involves you working on that patient within that 24-hour period goes towards your time. And then you just need to document that total time. Again, it doesn't have to be specific for the Medicare requirements. I would encourage you to do so because what you don't want is to submit that a patient to see their EHR and to call Medicare and say, this didn't happen. Because if you didn't then separately document, and normally nowadays your computer would be able to show a trail of where you spent time reviewing labs, but who wants to go through all of that? And also you just kind of have mud on your face explaining that to the patient. It's just not a great look. So the second way to bill is by medical decision making. And this is the preferred way to be billing, is based on medical decision making. So this is meant to reflect more the complexity of a patient. So your medical decision making is based on 2 out of 3. Finn, sorry, new dog, stop it. So this is the number of problems addressed at the encounter. So you want to make sure that you are listing these in problems. And the problems do not count. Remember, if you do not put something addressing the problem behind it. So just listing their diagnoses does not count. You have to put that it's stable, that it's ongoing, lifestyle, refills, no further workup needed. You have to do, or at this time being managed per GI, last note reviewed, patient report stable, but you have to put something behind it. If you just list the ICD-10, it doesn't count. So 2 of 3. So the number of problems addressed at that encounter. The second one being the data points to be reviewed or analyzed. And we're going to talk about what that means. And then the third being the risk of complications and or morbidity or mortality of patient. So when you're talking about the number of complexities of problems addressed, you can have something that's straightforward, so it's a self-limited or minor, something that's a low complexity where it's 2 or more self-reported minor problems, 1 stable chronic illness, 1 acute, moderate, where you're going to have 1 or more chronic illnesses with an exacerbation, 2 or more stable, and 1 new problem, or high. And high means that this is something that is likely to lead to poor outcomes for the patient. So when you're talking about complexity of data to be reviewed, these are tests, documents. So this would be looking at old ECGs, looking at labs, looking at old records, plain films, CTs. Now you're not billing for interpretation. You are including this in the complexity of the patient that you analyze these tests or reports. Old documents. So independent historians means previous documentation. So something that was documented by someone else in a previous visit, interpretation of tests, and then discussion or management of tests. So what does that mean? I had to look that one up. So that means if I saw a patient and I was like, wow, this is a weird ICD interrogation, or this is a wonky ECG, if I went to someone else and asked them to look at it with me. So if you were collaborating with another person within your practice, then that adds to medical decision making. So again, to review that test, so this would be prior notes, records, independent historian would be other people that are contributing to the patient's file, particularly if you have somebody that has a caregiver because they're no longer able, or this is things that are reported from outside sources, independent interpretation of tests. So this is important. If you are billing for an EKG, then you can put increased level of complexity based on the diagnosis of the EKG, but the time that was spent getting the EKG is separate from time billing. So when you were talking about the complications of the patient, or morbidity and mortality, when you're trying to establish the level of complexity of the patient, then this is supported by the patient having multiple diagnoses and then how they're coded. So hypertension unstable with retinopathy is a more complex patient than uncomplicated hypertension. So all of these things and being specific in your coding is to help support your higher level of complexity of the patient, thus a higher level of medical decision making. Other things that are important to include because they help predict risk for the patient is if you see things that make them more at risk for poor outcomes. So if you put in there hypertension, ischemic cardiomyopathy, EF of 20%, if you put patient has poor social support, limited understanding of nutritional counseling, limited resources for securing healthy meals, these are things that you would want to document because this makes this patient a higher risk patient for a complication. Thus, it is a higher level of medical decision making. If you put patient does not have reliable transportation, making it difficult for them to be compliant with visits, does not have phone connection for reliable telehealth follow-up. So documenting things that make somebody higher risk is important. So when you were looking at your patients, again, this is from the AMA, and this is kind of your quick list for putting all this together. So if you see a patient, you want to establish first, is this a new patient or an established patient? And then you go into one of your 992 codes. From there, you want to make sure that you clearly identify their chief complaint, and that can be put in the HPI, that you have your HPI, and that you include what you feel is medically relevant to the problems that you are addressing in your note. Now, again, don't exclude things that you need to be documenting for medical, legal, or for your own follow-up. For instance, I do an advanced heart failure clinic. So I put in my notes if somebody has a cardiomyopathy, If they're not on an indicated drug, then I would document that in my note. I would put patient has had hyperkalemia on ACEs, ARBs, or ARNIs. I would have that in my note. So don't forget that you're documenting not just for billing and coding, but for medical, legal, and for the people that come behind you to see the patient. So you're going to incorporate what you feel is relevant, and then you can have your data section, and you can put out your data that you have interpreted, or you can include that in your assessment and plan. And then for assessment and plan, it's important to make sure that you list all your diagnoses, and specifically, which you have to do now with the new codes anyways, and to include if it's being managed, evaluated, assessed, or intervened on. So you can't just list it. You have to put something out next to it that further defines what the course of treatment action plan is for that disease state. And then at the end of all of that, you want to decide if you're going to bill either on the complexity of this patient, which is what is preferred. And that makes sense because that's an easier way to do it, because you're not trying to keep up with all of the time. So if you have a patient that comes in and you're managing 2 stable chronic illnesses, that's a level 4 right there. If they're coming in with an acute new problem, that's a level 4. If the patient has a new problem or an exacerbation of an old problem that is high risk, it's a level 5. If it's somebody that's coming in with limited problems, low complexity, straightforward, so they have a wart and a sunburn, then that's a 3. So your medical decision making is the preferred way to be coding. And so the big change there is that you don't have to meet all these requirements for checking so many boxes on review of systems and physical exam. The other way to do it would be, let's pretend it is a straightforward patient or a patient with one. So for instance, in my indigent care clinic, I'll have people that come in with mental health problems. And so their diagnosis may be bipolar, but I spent 30 minutes before I went in the room reviewing old records, medicines that they've tried that didn't work, looking at their PQH9 mood disorder questionnaire. So reviewing data and looking at things. So I spent a significant amount of time on this patient, and then perhaps trying to get them in with a social worker or working on prior authorizations. So things like that. So I might spend an hour of time on the patient's care that day, but it was just a one stable chronic illness. So it would have been a low level of medical decision making based on complexity, but it was time exhaustive. So then I'm choosing to bill by time. So resources that I find helpful. So these are different things that I went through, and depending on your place of practice, you may want to look at different ones. So things that we did not touch on are split or shared visits, critical care services, because this is meant to be more outpatient focused. Other resources, so I thought this would be helpful. So these are things depending on your level of practice. So for instance, if you're in cardiology, as Jennifer is, then this might be a nice review, this thing on the ACC prior to releasing it, how they told to do the billing and coding. Whereas if you're in internal medicine, then this is a link to different resources from AACP. And with that, I will let you hit me with any very simple questions.